Hey, it's another episode of the Generalist CCFP 105 Topics Podcast. It's a good one. It's high yield info. It's a high yield condition. It's osteoporosis.
This episode was written and lovingly crafted by yours truly, Cezara, an incoming family medicine resident in Ontario, and it was then peer-reviewed by an amazing human, Bianca-Mariana Baila, UBC Family Medicine first-year resident.
And that beautiful voice you just heard was Cezara, and she is going to NASM next year. Yay! She's awesome because she wrote this, she found a reviewer for it, and she's also, of course, the co-host today.
Welcome to the Osteoporosis episode.
Let's do it. Let's get into it.
Osteoporosis Canada announced that new osteoporosis guidelines publication is expected later this year. Therefore, this episode will be discussed based on the current guidelines available.
And she does mean current because she messaged me partway through to tell me that there was Canadian Task Force upgrades even after she had just finished writing this episode. So this is fresh.
Yeah, we'll see what Caleb is talking about a little bit later. Thank you.
Objective 1. Assess the osteoporotic risk of all adult patients as part of the periodic health exam.
There is another episode about periodic health assessments. You can check that episode. Actually, there are two episodes, part 1 and 2. First things first, who should be assessed for osteoporosis and fracture risk?
There are 3 categories. First is
all women and men age 65 or more.
The other category is adults age 50 to 64 who are at high risk of fracture or who have already had a fragility fracture.
The last one, younger adults under the age of 50 who are at high risk of fractures.
Which we're going to talk about later on, I'm sure, what that means, high risk. So let's talk about how. Objective 2. Use bone mineral density testing judiciously.
The cornerstone is bone mineral density testing with dual energy X-ray absorptiometry, DEXA scan. However, it should be used wisely.
Let's follow the 2010 guidelines recommendations, and we're going to jump directly to BMD testing with DEXA scans just for people age 65 or more. Below that threshold, you need to prioritize the risk factor assessments before you do the BMD testing.
Yeah, now we are talking the new recommendation. The Canadian Task Force recommends prioritizing risk assessment first screening, FRAX2 without BMD testing, for women age 65 or older to prevent fragility fractures while considering patients' values and preferences.
And the awesome algorithmic pathway for testing is also included in the show notes if you're more of a visual person. So osteoporosis is considered the silent thief. It often has no clinical manifestations until a fracture occurs. Many of the fractures are discovered by chance when someone's doing a chest or abdominal x-ray for other reasons. So conduct a focused history and detailed visual exam looking for risk factors for low bone mineral density. The falls and fractures consideration is crucial.
Okay, so let's look at what's important to consider. Before 50, we look for
current or previous fragility fractures. We keep mentioning fragility fractures. What is that?
They are fractures caused by low trauma or minor impact. Yes, falls from standing height, own height, or even less, as well as daily activities, bending, twisting, coughing, or even sneezing. Therefore, when looking for them, ask about pain, especially back pain. We all have it, but focus on the pain with its characteristic features.
Hip, vertebrae, proximal humerus, and wrist fractures are the most frequently associated with osteoporosis and with increased future fracture risk.
During the physical examination, you may find some warning signs for different types of fractures. Measure height annually and check for vertebral fractures as they are the most common ones and can lead to height loss due to collapsed vertebra. Okay, so screen for use high-risk medications. The most important are glucocorticoids, which interfere with bone formation. Check for at least 3 months of use in the last year at a prednisone equivalent dose of 7.5 milligrams daily or more. Don't forget about COPD's treatment.
And here's the men's part, prostate cancer therapy. Here you're checking for androgen deprivation therapy. The androgens are required for developing peak bone mass and maintaining bone mass. So of course, if we're purposely blocking them, you're not going to build very good bone.
Other conditions and high-risk medications strongly associated with rapid bone loss or fractures are listed in the notes.
Moving forward, assessing the risk of developing osteoporosis for individuals 50 to 64 implies screening for. Remember, we just did these high risk before 50s. Now we're doing 50 to 64-year-olds.
You have to check for family history, parental history of hip fracture, medical history,
including fragility fractures. Now we're looking for fragility fractures after the age of 40.
and as specifically about vertebral fractures or osteopenia identified on the X-ray. Canadian Task Force has a strong recommendation that states to perform lateral thoracolumbar X-ray T4 to L4 or vertebral fracture assessment by DEXA scan if clinical evidence is suggestive of a vertebral fracture. Therefore, check for sudden onset of the back pain and its specific features.
Next, from a personal medical history perspective, you're going to check again for prolonged glucocorticoid use and other high-risk med use mentioned earlier, which if you really want to learn about, check the show notes for that big long table.
Yeah, and something new in this category is looking for low body weight, less than 60 kilograms, or BMI less than 20 kilograms per square meter, or major body weight loss more than 10% of weight at age 25 years old.
Other conditions strongly associated with osteoporosis are also listed below in two systems. So some of your genetic disorders, endocrinopathies, nutritional disorders, etc. It's a bit too much for us to do here.
Yeah. And also lifestyle, current smoking, high daily alcohol intake, just more than 3 units per day, or high daily caffeine intake, more than 4 cups per day.
Oh shit, I didn't know that. So to rule out secondary causes for osteoporosis, the Canadian Task Force recommends performing additional investigations based on your clinical assessment, keeping in mind that blood tests aren't indicated to make an osteoporosis diagnosis or to determine the risk category. We're just looking for secondary causes if you find that they do have osteoporosis.
If you are looking for secondary causes, you can measure serum levels of 25-hydroxy vitamin D for patients who will receive pharmacological therapy for osteoporosis and in other circumstances after 3 to 4 months of adequate supplementation, and do not repeat if the level is optimal.
We know the risk, more or less a cause. Next, we're going for the initial BMD testing. So let's move on to risk stratification and see how we're going to assess 10-year fragility fracture risk by combining the BMD or DEXA scan results and the risk factors.
Okay, so in Canada there are 2 tools available, and these 2 tools are validated in the Canadian population. We have the FRAX tool and we have the CAROC tool. The FRAX tool, the fracture risk assessment tool, uses several risk factors and optionally BMD testing of the femoral neck. Most of the osteoporosis risk factors listed in the notes are assessed for FRAX tool as well.
The 2010 version of the Canadian Association of Radiologists and Osteoporosis Canada, or CAROC, considers age, sex, fracture history, and glucocorticoid use to determine your 10-year absolute risk. The BMD is required to calculate the risk for the CAROC score. It stratifies women and men over the age of 50 into the 3 zones of risk that are familiar probably to you. That's low, less than 10% risk in the next 10 years, moderate, 10 to 20%, and high is over 20% risk.
Individuals with a lumbar spine or total hip T-score, the score from DEXA scan, of less than -2.5 should be considered at least at moderate risk.
Therefore, if a clinical risk assessment tool suggests
a low fracture risk, then encourage lifestyle changes and reassess the risk in 3 to 5 years.
If that clinical risk tool suggests the moderate fracture risk, so that's the 10 to 20% risk in the next 10 years, consider getting a lateral thoracolumbar x-ray of the T4 to L4 or fracture assessment by DEXA to rule out compression vertebral fracture. This can help you further stratify within that moderate fracture risk score based on additional risk factors and guide your treatment. So you kind of end up going towards treating with bisphosphonates, etc., if there's one or more additional risk factors and their moderate fracture risk, and then repeat BMD testing and reassess the risk every 1 to 3 years.
So now we have the high-risk fracture that above 20% for 10 years. And if the patient is at high risk or has prior fragility fractures of hip or spine, or more than one fragility fracture are present, consider treatment based on the patient's preference and continue without a drug holiday.
And to wrap up, BMD testing with DEXA is not indicated unless the patients are 65 or older or at moderate risk of fracture, that is 10 to 20%. To wrap up, testing with DEXA is not indicated unless they're 65 or more, they're at moderate risk of fracture, that's the 10 to 20% 10-year risk, and the results are likely to alter patient care. So if they tell you they're not going to do anything, they're not going to take bisphosphonates, they're not going to accept OT to look at their home for fall risk, then like anything else, why do the testing?
And also remember that starting in May 2023, just this month, Task Force recommends prioritizing risk assessment first screening, so using FRAX2 without BMD testing for women aged 65 or older to prevent fragility fractures while considering patients' values and preferences.
You heard it here, brand spanking new. Objective 3. Counsel all patients about primary prevention of osteoporosis, especially those at higher risk.
In general, if there are no risk factors for rapid loss of bone mineral density, lifestyle changes are enough to prevent osteoporosis. For those at high risk, such as young premenopausal female athletes and patients with eating disorders, focus on preventing calorie deficit by improving the diet.
Encourage weight bearing, remember Wolf's Law, and resistance exercises at least 30 to 60 minutes per day, at least 3 days per week to reduce the risk of falls and fractures and improve the quality of life for those folks with osteoporosis.
Weight-bearing exercise could be as simple as walking, climbing stairs, or anything else that implies using your own weight. Resistance exercises imply muscle strengthening and lifting weights or using resistance machines. Osteoporosis Canada has a program called 2 Fit to Fracture that includes exercise recommendations for people impacted by osteoporosis. You can check the notes and see a brochure there.
Yeah, it's awesome. It shows some exercises. That'd be a super good handout to give to patients. Of course, bone health is important at every age, and a healthy diet may help with this. Like, who are we not going to advise to have a healthy diet? In this case, we recommend daily elemental calcium intake through both diet and supplementation over the age of 50, and it should be at least 1,200 milligrams according to the Canadian Task Force.
Patients with malabsorption syndrome, such as celiac disease, inflammatory bowel disease, and so on, may require more than that. So, certain medication change the amount of calcium that is absorbed or excreted.
Calcium supplements do interfere with the absorption of iron and thyroid hormones. So, if people are taking levothyroxine or iron for whatever reason, make sure that they leave a gap in time in between when they take them. Cezara has also included an awesome table that I always forget of some foods that people can take that contain calcium, and a lot of people are going to appreciate ways that they can increase their calcium through real food instead of taking supplements. So try and get 2 or 3 of those things in your brain that you can recommend.
And now we are in Canada, so the amount of sunlight we get in Canada is insufficient to produce enough sunshine vitamin D. In addition, as we become older, we produce less vitamin D. Moreover, there are few food sources of vitamin D, hence year-round vitamin D supplementation is advised for all Canadian adults.
Healthy Canadians over 50 should take in at least 400 to 1,000 international units of vitamin D3. This is cholecalciferol if you're fancy. This is to achieve optimal vitamin D levels. People with osteoporosis, multiple fractures, or conditions affecting vitamin D absorption should take more than that 1,000 units per day. Daily doses up to 2,000 international units are considered safe, and you don't need to do monitoring.
Yes, and according to a recent study, even though you are using more than 2,000 international units of vitamin D, you won't benefit from this because the risk of fracture among the general healthy population compared to a placebo was not significantly reduced. In Canada, there are lots of food resources vitamin D fortified. So you'll find, again, a table that is going to go in more detail.
Gotcha. Oh, and that's foods that have vitamin D. So vitamin D sources in the table. Awesome. Love it. Protein intake is also recommended to be kept adequate, 1 gram per kilogram per day, especially in fall-prone older adults who are losing weight. Higher protein intake was associated with fewer falls.
Smoking cessation and alcohol consumption limitation may benefit both the bones and general health as well.
Objective 4. In menopause or perimenopause, provide advice about fracture prevention that includes improving physical fitness, reducing alcohol, smoking cessation, risks of physical abuse, and environmental factors that may contribute to falls.
The North American Menopause Society reinforces the importance of non-pharmacological measures and lifestyle modifications for all women. Everyone has to take care of their habits, regardless of their BMD, clinical risk factors, or fracture risk, to support, again, general and bone health.
These general approaches, however, are not going to prevent bone loss and early menopause. That's going to happen no matter what. It will not significantly increase BMD in postmenopausal women, and there's certainly not adequate treatment for women who already have osteoporosis. The daily intake of calcium recommendations for both postmenopausal women and women with normal BMD is 1,000 milligrams to 1,200 milligrams, with an upper limit of 2,000 milligrams of calcium.
Current recommendation is that postmenopausal women consume at least 800 international units of vitamin D per day, although the optimal intake has not been established in premenopausal women, but 600 international units of vitamin daily is generally suggested.
There's a ton of misconceptions regarding supplements that might be beneficial to women's health, but studies have shown that only a few might have a positive effect. And so here we're going to mention a couple of them.
Probiotics may help prevent bone loss caused by estrogen deficiency because gut microbiota can affect several aspects of bone health, including calcium and vitamin D absorption and immune response. Phytoestrogens, including isoflavones, are plant-derived compounds with weak estrogenic activity that may have a moderately beneficial effect against estrogen deficiency bone loss, according to some studies.
Regular weight bearing and resistance exercises need to be encouraged for bone health and overall health. Lifting or pulling with forward spine flexion or rotation needs to be avoided by women with osteoporosis, of course, especially those who already have vertebral fractures.
Again, encourage smoking cessation and alcohol intake limitation and avoiding any harmful event that puts too much pressure on the osteoporotic body, for instance, physical abuse.
Every year, at least a third of women 65 and over fall. And as people age, their chance of falling and breaking bones increases, and that can be an inflection point in their life, which is bad. Since falls are the primary causes of these fractures, efforts to prevent them should be encouraged as well. You know, we get accused of not advising people on nutrition and not smoking and not drinking, but I feel like half the episodes have included that to some degree. Anyway.
Yes.
Objective 5. In patients with osteoporosis, avoid prescribing medications that could increase the risk of falls.
Conduct a focused history to identify a fall in the last year and do a physical examination to assess fall risk by using the Get Up and Go test. So, check the ability to get out of a chair without using arms and walk several steps and return. Postural hypotension, cardiac arrhythmias, and any neurological problems should also be assessed.
And is there a timeline attached to the Get Up and Go? It's like 10 seconds, something like that? Yeah, I think there is a timeline attached to it and we'll include it in the show notes. Also, always review your patient's medication list, especially in the elderly, including over-the-counter meds they might be taking on their own or that their naturopath decided they should take. Think about medications that can cause drowsiness, dizziness, hypotension, Parkinsonian effects, ataxia and other gait disturbances, visual disturbances, osteoporosis, and bleeding. Seems like a never-ending list.
Yes, but to make things a little easier, consider medication that suppress the central nervous system, such as those that reduce alertness and cause slower reactions and movements. These include anxiolytics, benzodiazepines, diazepam, lorazepam, antidepressants, especially tricyclic antidepressant amitriptyline, antiepileptics, alpha-adrenergic blockers, benign prostatic hyperplasia and pheochromocytoma medication, and painkillers. Don't forget about opioids. More examples are listed in the notes.
Are they ever? It's a giant list, and you must remember all 45 of them. Kidding.
Okay.
Nobody will remember that. Home stretch here, folks. Objective 6. Provide advice and counseling about fracture prevention to older men as they too are at risk for osteoporosis.
Indeed, osteoporosis is commonly thought to be a woman's disease, but older men are also susceptible to bone loss.
Anything you can do, I can do better.
I can do anything better than you.
No, you can't.
Yes, I can.
No, you can't.
Yes, I can.
No, you can't.
Yes, I can. Yes, I can.
Men have fewer research studies on osteoporosis than women. According to Osteoporosis Canada, at least 1 in 5 men will break a bone as a result of osteoporosis, and men account for 1/4 of the 30,000 hip fractures caused by osteoporosis in Canada every year.
And they climb ladders until they're 80 years old in the winter to clear snow off the roof. It's madness. If you're over 65, please stay off ladders. Everyone, both men and women, should take the same steps to prevent fractures and promote bone health. Therefore, encourage men to engage in weight-bearing and resistance activities, just as we talked about before. Eat a healthy, balanced diet rich in dairy products. Avoid smoking and limit alcohol consumption. Brilliant. Objective 7. Treat patients with established osteoporosis regardless of their sex.
Here we are at the treatment. Treatment adherence to osteoporosis pharmacotherapy is quite low. Therefore, individualized management plans, lifestyle changes, and pharmacological therapy should be used to improve this adherence. In general, pharmacotherapy reduces the risk of vertebral fracture by 30 to 70%, depending on the agent and, again, the level of adherence.
Before starting therapy, the potential benefits and the risks need to be discussed like anything else you do in medicine to support informed decision-making by the patient. They have to be on board, otherwise what's the point? Bisphosphonates have been shown to reduce hip, non-vertebral, and vertebral fractures for both women and men. There's no evidence that adding testosterone reduces fractures in men, although that's become a common trend.
Yes. So, when prescribed wisely, women will benefit from hormone replacement therapy, estrogen with or without progesterone, when it's already been used for managing menopausal symptoms, or another medication, raloxifene, a selective estrogen receptor modulator. Synthetic parathyroid hormone prevents bone loss and increases lumbar spinal BMD as well.
Just another reason to use estrogen for your folks with vasomotor symptoms. Gains in bone mineral density decline once treatment is discontinued. Therefore, you need to follow it by long-term anti-resorptive therapy with a bisphosphonate or receptor activator for nuclear factor ligand inhibitor after completing the treatment course. Of course, I know what that is. The first new treatment in almost a decade, called romosozumab, which is a sclerotin inhibitor, has been shown to reduce fracture risk as well. Fancy pants. Keep your eyes out.
It significantly and rapidly, over 1 year, increases bone formation and decreases bone resorption in both the lumbar spine and hip. And calcitonin salmon is no longer used in Canada. For more information regarding the pharmacare plan's coverage rules, check with your local services.
What is calcitonin salmon?
It's a medication that had been used in the past for osteoporosis, but there is no longer used in Canada.
The salmon part is throwing me off.
Yeah.
All right, that's incredible. Thank you, Cezara, and thank you so much to Bianca for peer reviewing and making this thing happen. You guys are incredible, and I'm excited for you for heading out to NOSM. It's cool.
Thank you so much for all your support, and looking forward to working in other episodes maybe in the future. Thank you.
Yes, please. This has been the General CCFP 105 Topics podcast on osteoporosis. Thank you for listening. Reach out with any feedback you have. We'd love to hear from you, especially if it relates to 5 stars on Apple or Spotify or anywhere else. And if you want to get involved, incredible humans like Cezara straight up just send a message and go, I want to help. And then they help. And then they make cool things like this that help their colleagues across the country. Thanks, Cezara.
Bye-bye.
Bye-bye.